Good morning everyone. I am Dr. Chitra Menon, your Medico Pathology faculty, and today we are dealing with the second part of the test and discussion series. So without further ado, let's take a look at the first question. So what is it? 2-year-old child presents with hepatosplenomegaly, developmental delay and bone pain. And the bone marrow biopsy is shown below. Okay, genetic testing reveals mutation. So what are we discussing here? So what we are discussing here is a topic called lysosomal storage disorders. Okay, so we are dealing with the lysosomal storage disorders. This is, as far as your PG entrance is concerned, an extremely difficult and an extremely confusing topic. So what is the pathology behind lysosomal storage disorders? So this is your cell, and inside the cell, what do you have? You have your nucleus. Then near the nucleus, you have what is called your rough endoplasmic reticulum, your RER, that is rough endoplasmic reticulum, wherein it is called rough because there is the presence of ribosomes attached to this rough endoplasmic reticulum. Okay, so near that, you also have something called the Golgi apparatus. So Golgi apparatus essentially functions as a post office. Okay, so whatever proteins that are being manufactured in the rough endoplasmic reticulum, for example, your lysosomal proteins, these go into the Golgi apparatus, and from the Golgi apparatus, the Golgi apparatus applies what is called a sticker onto the protein. Like for example, if you have a protein like lysosomal enzyme here, it attaches a mannose 6-phosphate receptor onto the protein, the protein, that is the enzyme or whatever it may be. Then what happens? Then it is taken out from the Golgi apparatus, and if it is an enzyme, it is taken into the lysosome. So now inside the lysosome, you have your enzyme which has been labeled with this mannose 6-phosphate receptor or whatever. Just understand that all these are just details. Just understand the enzymes, they are being manufactured in the rough endoplasmic reticulum. From the rough endoplasmic reticulum, they are taken to the Golgi apparatus, and the Golgi apparatus here functions as a post office, and essentially it is giving an address to where each and every protein needs to go. So there are some proteins which are meant for the lysozymes. So these are the lysozymal proteins, or rather the lysozymal enzymes. Okay, these are called your acid hydrolases. So it comes into your lysozyme. So it is stored in the lysozyme. So suppose then what happens inside the lysozyme? So here you have a complex substance that is taken into the lysozyme for breakdown or hydrolysis. So in normal cells, what happens is you have your complex substance which is A, which is changed to B, and it is changed to C. So this is what happens in normal cell, provided all the enzymes that are required for the breakdown of that particular substance is present. This is how the normal looks like. But what happens if one or suppose either this enzyme is absent or this enzyme is absent? What happens? The substrate that is supposed to undergo degradation, it accumulates inside the cell. Similarly, whatever this substance which in the regular process will get degraded to non-toxic forms, but here the degradation is not happening. So the substrate, it can change into its toxic form and also cause and can also cause cell toxicity. Okay, so this is how lysosomal storage disorders cause some disorder. Lysosomal storage disorders cause pathology. So again, in the normal cell, normal homeostasis of the cell, what happens is these lysozymes, there are some autophages. That is, there are some molecules inside the cell which has to combine with the lysozyme to form what is called a phagolysozyme, and that phagolysozyme results in degradation of the normal protein or whatever the substance is. Now, suppose if there is a defective fusion of autophages with lysosome. So what is happening? So the degradation is not happening properly. So there is defective degradation of organelles. Now that results in either accumulation of toxic products or it results in accumulation of abnormal substrate or protein. Now these accumulation, these toxic products, they result in cell death as they activate some kind of inflammatory process. Similarly, these abnormal substrate, these also result in ROS, that is the reactive oxygen species formation, and result in cell death. So this is the pathophysiology of how lysosomal storage disorders cause their symptoms. So what is happening? What is the function of lysozyme? So lysozyme contains some enzymes called the acid hydrolases. And this acid hydrolases, the function is to degrade either complex substances into much simpler substances or to degrade toxic metabolites into non-toxic metabolites. So these enzymes, that is these lysosomal enzyme, otherwise known as acid hydrolases, they are usually manufactured inside the rough endoplasmic reticulum. From the rough endoplasmic reticulum, these are taken into the Golgi apparatus. The Golgi apparatus here functions as a labeling unit or a post office and is attaching a label to all these enzymes. For example, those enzymes which are supposed to go into the lysosomes are being given a tag or a metabolite or an address like mannose 6-phosphate receptor. So then once this Golgi body gives this name to that particular lysozyme enzyme, these are taken into the lysozyme. Now this lysozyme functions in a whole lot of ways. If there is presence of some intracellular pathogen, or if there is presence of some abnormal molecule or a complex substance, there is the formation of what is called an autophages, that is molecules which are capable of eating the toxic substances. Now these autophages, these come and bind with the lysosome, and that causes degradation of the said complex substances. This is what happens in a normal cell. So when there is defective in any step of this said process, that can lead to your lysosomal storage disorders. So now that you've got an understanding of the pathophysiology of the lysosomal storage disorders, let's think. When you are talking about the treatment of this lysosomal disorders, you can treat it in 3 ways. The first one is you can replace the enzyme that is deficient, right? For example, if enzyme X is deficient in a human, you can give enzyme X to that patient. So that is the first method of treatment. Now the second method is substrate reduction. Now we know that if a particular lysozyme like lysozyme or acid hydrolase is absent, the substrate does not undergo proper degradation and the substrate accumulates. So suppose you are restricting the amount of substrate that a patient is intaking, you can reduce the need for the enzyme to act. So that is the second method of treating, that is substrate reduction. Then again, you also have another treatment called molecular chaperone therapy. Okay. So now we are coming to the names of some lysozymal enzymes, lysozymal storage disorders and their enzyme and the enzyme which is deficient. So firstly, you have glycogenesis. Suppose there is a defect in glycogenesis. You have what is called, here this is not an exhaustive list. These are just commonly asked questions. So you have type 2, that is Pompey's disease. And the enzyme that is absent is alpha 1,4 glucosidase, which is a lysozymal glucosidase, and glycogen is what is getting accumulated. That is the first one. Second one is sphingolipidosis. That is the second type of lysosomal storage disease. So here you can have both GM1 gangliosidosis or you can have GM2 gangliosidosis. Okay, so first we have your GM1 gangliosidosis. So this can be your type 1 and your type 2. Okay. So your type 1 is an infantile one and it is generalized, and type 2 is the juvenile form. Okay, so what is deficient here is the GM1 gangliosidase, that is the beta galactosidase. Okay. Now moving on, I said you can have sphingolipidosis can either be GM1 gangliosidosis and GM2 gangliosidosis. So GM2 gangliosidosis, here are a few examples. You have Tay-Sachs disease, where the deficient enzyme is hexosaminidase A. Then you have what is called the Sandoff disease, wherein both hexosaminidase A and B are absent or deficient. Then you have the GM2 gangliosidase variant AB, that is the ganglioside activator protein. This is the substance that is deficient. So now we are done with sphingolipidosis. Now we'll move on to the next one, that is sulfatidosis. Now one example is what is called metachromatic leukodystrophy, wherein what is deficient is the enzyme aryl sulfatase A. Then multiple sulfatase deficiency. So here you can have several enzymes that are deficient. So it can either be aryl sulfatase A, then steroid sulfatase, then iduronate sulfatase, then heparin N sulfatase. Okay. Another example is your Krebs disease. Here what is deficient is galactosyl ceramidase. Then you have your Fabry disease. Here your alpha galactosidase A is deficient. Then you have your Gaucher disease. In Gaucher disease, your glucocerebrosidase is deficient. Then you have your Niemann-Pick disease, wherein sphingomyelinase is deficient. Okay, so now we are done with glycogenosis, sphingolipidosis, sulfatidosis. Next one is your mucopolysaccharidosis. Okay, so here you have the mucopolysaccharidose 1H, that is your Hurler syndrome, and what is deficient is your alpha L iduronidase. Then you have your MPS 2, that is Hunter, wherein you have iduronate 2 sulfatase deficiency. Then you have your mucolipidosis. So in your mucolipidosis, again what is deficient is, it is called your eye cell disease. Here you have a deficiency of phospholipase enzyme for formation of the precursor molecule. Okay. Now some other diseases, again you have fucosidosis, wherein what is deficient is alpha fucosidase. Then you have mannosidosis, where what is deficient is alpha mannosidase. Then you have another disease called Woolman disease, where what is deficient is acid lipase. Now this is one of those kind of things that you just have to know. So when you're talking about lysosomal storage disorders, I hope you understand what happens when there is, what is the pathology behind lysosomal storage disorders. So under glucogenosis, you have type 2, that is the Pompe's disease, where alpha-1,4-glucosidase is the deficient enzyme. Then under sphingolipidosis, you have GM1 gangliosidosis and GM2 gangliosidosis. We'll take a short break now. So welcome back. So we were talking about the different lysosomal enzymes. So let us look at what the question was about. So you have a lysosomal enzyme wherein you have hepatosplenomegaly, developmental delay, deficiency of glucocerebrosidase. So what is that? That is Gaucher's disease. So let us see what do you mean by Gaucher's disease. Okay. So Gaucher's disease, it is an autosomal recessive disorder characterized by mutations in glucocerebrosidase. Okay, so Gaucher glucocerebrosidase. So where is it coming from? So we know this glucocerebrosidase is the enzyme that is absent. So what is the function of this enzyme, that is glucocerebrosidase? The function of this enzyme is catabolism of glycolipids. Okay, so where do you get glycolipids from? So what is the origin of this glycolipids? So these glycolipids these come from the cell membrane of senescent leukocytes and RBCs. Okay, so Gaucher's disease, you have the deficiency of glucocerebrosidase, and here what is happening is there is a defect in the glycolipid breakdown. So this glycolipid, it is coming from the cell membrane of senescent leukocytes and RBCs, and so glucocerebrosidase enzyme is not happening. So this glycolipids, these are getting deposited. So where are they getting deposited? So these can either get deposited in the central nervous system or in the phagocytes. Okay, so either this can result in the glucocerebroside being deposited in the phagocytes and in the central nervous system. So from this you can understand, by the word phagocyte is not something that is seen at a particular location. It is seen throughout the body. So there can be depositions throughout the body. Now along with that, an interesting point is, in the pathology of Gaucher's disease, 3 cytokines also play a role. So interleukin 1, interleukin 6 and TNF, these also play a role in the pathogenesis of Gaucher's disease. Now again, talking about Gaucher's disease, you have 3 types, that is type 1, type 2 and type 3. So type 1 is chronic non-neuronopathic. Then type 2 is acute neuronopathic. And type 3 is the intermediate form. Okay, again, I said this glucocerebroside, it can get deposited in the phagocytes and in the central nervous system. So when you are talking about types of Gaucher's disease, you have 3 types. One is your chronic non-neuropathic Gaucher's disease. So from that itself you can understand that non-neuronic. So central nervous system is not affected. So what is affected? Only phagocytes are affected. And because phagocytes are affected, it can have a splenic and skeletal involvement. Okay. Chronic non-neuronopathic, the central nervous system is not affected. You can have phagocytes that are affected. Because phagocytes are affected, there can be splenic involvement and skeletal muscle involvement as well. So in this patients, as the name suggests, it is chronic. So as far as the lifespan is concerned, lifespan of such patients is concerned, it is not much shortened. Okay, because it does not affect any vital organs like your CNS. So the lifespan is not much shortened. Now coming to the next, that is the next part, that is type 2. It is acute neuronopathy. So here there is an infantile acute cerebral pattern. Okay, so here from the word itself you can understand that the central nervous system has been affected. So there is hepatosplenomegaly. Yes. Along with that, you also have progressive CNS involvement as well. Now, because of this progressive CNS involvement, it can lead to early death. Okay. So, yeah, again, type 1 and type 2, type 1 CNS is not involved, type 2 CNS is involved. Now, as I said earlier, phagocytes are involved, so spleen will be involved. Now, there are instances where spleen is involved to such an extent that the spleen alone weighs about 10 kg. So, that can be the extent of involvement of spleen. So, now you know what is type 1 and type 2, and type 3 I said is intermediate. So, from that you understand there is systemic involvement that is characteristic of type 1, and along with that you can also have progressive CNS involvement. So that are the 3 types of Gaucher's disease. Now, what do we see in Gaucher's disease? So if you look at the question, you can see there is deposition of cells which are called Gaucher cell. And this Gaucher cell is typically seen deposited in the bone marrow and is said to have a wrinkled tissue paper appearance. Okay, so this is your Gaucher cell. So, continuing. Now, morphology, what you see is, you see distended phagocytic cells called Gaucher cell. Now, where is it seen? Where is it seen? So, it is seen in spleen, bone marrow, liver, lymph nodes, tonsils, Peyer's patches, thymus, and even in lungs. Okay, so it is a large cell, about 100 micrometer in diameter, with a dark eccentrically placed nuclei, and it is usually positive for PAS, that is a periodic acid Schiff. Then this characteristic wrinkled tissue paper appearance it is because of elongated distended lysosomes. Okay. Now, one extra point I want you to know is deficiency or mutation in this glucocerebrosidase gene is found to be one of the people with mutations in this gene is found to have a higher incidence of Parkinson's disease. So that is it about Gaucher's disease. So summarizing, now you've learned so many things about Gaucher's disease. Now from the point of view of exams, how will you be able to answer if the question is about Gaucher's disease? So first thing will be the history. Okay, you will have a history of usually a child, about 2 to 3 years or even less. That will be the history. The child will have hepatosplenomegaly and there will be words like bone pain or bone marrow involvement or something like that. That will be the history. Then clinical examination, again you can have hepatosplenomegaly. Now third thing is in histopathology, as far as pathology question is concerned, you will have this wrinkled tissue paper appearance that we saw earlier. So that is almost pathognomonic of Gaucher's disease. I think everyone, if you see that wrinkled tissue paper appearance, you will be able to say it is that same enzyme. That is the enzyme. So what extra point that you need to know is it also leads to an increased chance in Parkinson's disease, and that it is PAS, which is a stain, that is periodic acid shift. That stain is positive in this disease. So in a nutshell, this is all you need to know about about Gaucher's disease. So again, you will have a disease where you will have a condition in which a child is presenting usually with hepatosplenomegaly, with some sort of mental retardation. Then there might be presence of Gaucher cells. Then the enzyme which is absent is glucocerebrosidase, and this gene causes an increase in Parkinson's disease. So that is it about Gaucher's disease. So here you can see there are two other diseases that has been described. So that is your Tay-Sachs disease and your Niemann-Pick disease. And here this is the Gaucher cell. So now we will see what is meant by Niemann-Pick disease and what is the Tay-Sachs disease. So Niemann-Pick disease, A and B. Okay. So here in Niemann-Pick disease, as we learnt earlier, the enzyme which is defective is sphingomyelinase. And because of this sphingomyelinase deficiency, there is deposition of sphingomyelin. Okay, then this again you can have two forms. That is, you can have type A and type B. So your type A, it is a severe infantile form with extensive neurologic involvement. We'll take a short break. Okay, so type A, it is a severe infantile form with extensive neurologic involvement. And here what is happening? You have deposition of sphingomyelin. Deposition of sphingomyelin. And what does that cause? That causes progressive wasting and early death. So from that you can understand, so it usually presents at birth and it is very evident by 6 months. So here the patient is going to have a protrudent abdomen, hepatosplenomegaly, and all the other things that you can see. Now in type B, you have organomegaly, but there is no CNS involvement. So in type A, you have CNS involvement, and in type B, you do not have any CNS involvement. Now, one point what I want you to know is both these, that is Niemann-Pick disease A and B, they are both seen to have an increased incidence in that Ashkenazi Jew population. And in these cases, something called paternal imprinting is taking place. Paternal imprinting. So what do you mean by paternal imprinting? So paternal imprinting, as we learned yesterday, maternal imprinting means the maternal gene is silenced. So paternal imprinting means the paternal gene is silenced. So, in Niemann-Pick disease, the paternal gene is silenced, and it is the maternal gene that, the mutated maternal gene, that is causing glucocerebrosidase, sphingomyelinase deficiency. And the location of this gene is in the 11th chromosome. Okay. Now we learned about the pathophysiology. Now coming to the histopathology, like what do you see in smears? As here you can see, this is your Niemann-Pick disease. So here you have foamy vacuolated appearance. So again, talking about Niemann-Pick disease, you have sphingomyelin. What is sphingomyelin? It is something that is present in the cell membrane. It is a phospholipid that is present in the cell membrane. Now, in normal case, it has to undergo degradation in the lipozyme, but this degradation is not happening. So what is happening? These progressively get accumulated within the lysosome. Okay, so these are getting accumulated within the lysosome, and you have a cell which is enlarged with foamy appearance. What do you mean by foamy? Foamy means bubble-like or vacuolated. Okay, so this foamy appearance is because of sphingomyelin deposition or cholesterol deposition. Okay, now that is what you see in electron microscope, what you see in normal microscopy. So in electron microscopy, you have a very characteristic appearance, that is zebra body appearance. Okay, so what are zebra bodies? So these zebra bodies those are caused by your vacuoles, which are membranous cytoplasmic bodies, and these are arranged in a concentric pattern, causing the appearance of a zebra body. Again, it is not a pathognomonic condition of Niemann-Pick. There are several conditions in which this appearance can be seen, but it is commonly associated with Niemann-Pick disease. Now, again, all of you know, I think, that Niemann-Pick disease, classically you think Niemann-Pick disease, you say retinal cherry spot. That is also a characteristic feature of Niemann-Pick disease. Again, it is not specific, it is just characteristic. So now we saw Niemann-Pick disease type A and type B. Now we will see what is Niemann-Pick disease type C. So type C, now this in contrast to Niemann-Pick A and B, which is because of deficiency of sphingomyelinase gene, which is present on chromosome 11. Here you have two genes that are affected. Two genes which are called NPC1 and NPC2. So in 95% of cases, NPC1 is affected, and in 5% NPC2 is affected. So here, the primary defect is in non-enzymatic lipid transport. Okay, so the defect is in non-enzymatic lipid transport, that is transport of free cholesterol from lysosome to cytoplasm. So in Niemann-Pick C, even though the name says that it is Niemann-Pick C, it is different in the sense that here two genes are involved, that is NPC1 and NPC2, and there the defect is in the non-enzymatic transport of lipids, that is the transport of extra cholesterol from the lysosome to the cytoplasm. So here what is different is it can have a very characteristic and a very bad prognosis. So clinical features, it usually presents as hydrops fetalis, stillbirth, then as neonatal hepatitis, then as progressive neurological defect. Okay, so some other features can be ataxia, supranuclear gaze palsy, dystonia, dysarthria, and psychomotor regression. Okay, so now I hope you understand what is meant by Niemann-Pick disease. So Niemann-Pick disease A and B, commonly seen in Ashkenazi Jews. Then paternal imprinting is there. It is seen in chromosome 11. So here it has two types, type A and type B. And type A is a severe infantile form, and type B presents with organomegaly and no CNS involvement. Now, Niemann-Pick C is very different from type A and B. Here, it is not in the sphingomyelinase that is deficient, but rather there are two genes, that is NPC1 and NPC2, that have been mutated in Niemann-Pick disease, and that leads to a defect in the non-enzymatic transport of lipid, that is in the transport of free cholesterol from the lysosome to the cytoplasm, and it usually presents at birth and has very severe prognosis. That is, it presents either as a hydropis fetalis or as neonatal hepatitis or with progressive neurological disease. Now, now that we have dealt with Niemann-Pick disease and with Gaucher's disease, let us discuss the next type of disease, that is the Tay-Sachs disease. Now again, as I said in the beginning, lysosomal storage enzyme, it is a very confusing and complex factors, but the commonly what I have enumerated above is the commonly asked diseases and the enzymes which are present in these, which are involved in the pathogenesis of those diseases. So we have now dealt with Gaucher's disease and with Niemann-Pick disease. Now we are dealing with Tay-Sachs disease. Now Tay-Sachs disease, it is a GM2 gangliyosidase. A GM2 gangliyosidase. So here the hexosaminidase alpha subunit is different. So in hexosaminidase, so it is involved, it is a GM2 ganglioside. So what is the pathology? So here, before we go to the Tay-Sachs disease, what do you mean by GM2 gangliosidases? So here you have 3 lysosomal storage disorders caused by deficiency of beta hexosaminidase, wherein what is happening? You have the inability to catabolize the GM2 ganglioside. Okay, so again, here when you are talking about GM2 gangliosidase, you have 3 genes that you need to know. 3 genes. One is the first one is the hex A gene, and that is present in chromosome 15, and it codes for the alpha subunit of hexosaminidase. Okay, then you have the hex B gene, which is present in the chromosome 5, and that codes for the beta subunit of hexosaminidase A and B. So now, and then the third one is GM2A. That is also a gene which is present in chromosome 5. Okay, so that is it about GM2 gangliosidases. Now, coming right to Tay-Sachs disease. So in Tay-Sachs disease, what is happening? Here, there is a mutation in the alpha subunit of hexosaminidase A. So, what do you get? So, you have GM2 gangliosidases in almost all tissues, and here this abnormal GM2 gangliosidase accumulates in the neurons. Now, these neurons can be in the central nervous system, the autonomous nervous system, and in the retina. So here what you see is, when you take a histopathology, that is when you see on microscopy, what you see is you will have neurons which have cytoplasmic vacuoles. Okay, so you have neurons with cytoplasmic vacuoles, and this is called the characteristic onion skin layer of neurons. Then another characteristic finding that you have is cherry red spot in the macula. Okay, now when you're talking about a patient with Tay-Sachs disease, there will be the clinical features is, it is he or she is going to be normal at birth, but the symptoms will start to occur from 6 months, and there will be motor and mental degradation, then motor incoordination, intellectual disability, etc. Okay. So that is it about Tay-Sachs disease. So now what we have learned till now is about what is the pathophysiology of lysosomal storage disorders, and 3 commonly asked lysosomal storage disorders, namely Gaucher's disease, then your Niemann-Pick disease, and your Tay-Sachs disease. So these, I would advise that you study it by writing, because it is extremely confusing. So the question we were dealing with is Gaucher, the scenario and the characteristic Gaucher cell. So the answer is Gaucher's disease. Okay. Now let's take a look at the next question. Here I have, here as you can see, there are also glycogen storage disorders and pictures dealing with glycogen storage disorders that we will discuss a little bit later. So what is the most likely mode of inheritance? So here this question is incomplete. Now when you are talking about lysosomal disorders, it is mostly autosomal recessive. Okay. So next question. I think 2 questions have been re-asked. So now let's look at the 5th question, which is the most likely mode of inheritance. So here you can see what is the, here you can see you have a female who is affected, then you have a male who is affected in the next generation, and in the generation after that everyone is affected. So first of all, how you approach such a question is, first you have to decide whether it is a dominant disease or a recessive disease. Okay, so to understand if it is a dominant disease or a recessive disease, if every generation has the disease, it is a dominant disease. If the disease skips generation, it is a recessive disease. So then you have to know whether it is X-linked or autosomal. So if it is X-linked, usually the males, if it is an X-linked dominant, the males are going to be affected. If it is X-linked, the males are always affected. If it is an X-linked dominant, the females will also be affected. If it is an X-linked recessive, the females will not be affected. Now, if it is autosomal dominant, either can be affected. If it is autosomal recessive, only if there are 2 alleles, that is from both sides of the family, if the allele is present, that is only when the child or the offspring will be affected. So here we are talking about, so here you can see the female is affected, then in the next generation someone is affected, and the generation after that also someone is affected. So from that you can understand that here it is dominant disease. So now you have to check for whether it is autosomal or it is X-linked. So here if it is autosomal, if it is X-linked, both X-linked dominant, both males and females will be affected. But if it is X-linked recessive, as I said earlier, no, only the male will be affected. So from this picture, it is an example of an X-linked dominant condition. We'll take a small break.